Hi everyone, my name's Mary and I'm one of the residents at Nepean. This presentation is going to look at patients with hip fractures. In particular, we're going to focus on the JMO perspective, so issues that you might encounter when looking after a patient with hip fractures on the ward, and we're going to look at both pre-op and post-op considerations. Just for a bit of background, hip fractures are a sign of frailty, and so patients who present to hospital with a fractured hip are some of the frailest patients that you might encounter. They often have a lot of comorbidities. Just looking at some stats, up to 50% of patients with hip fractures also have some sort of endocrine disorder, whether that's metabolic disorder or diabetes. About 40% will have some sort of circulatory disorder during their admission, most commonly hypotension, hypertension, or AF. And about a third of them will have some sort of mental or behavioral disorder during the admission as well, whether that's delirium or pre-existing dementia. So these are all issues that we'll talk about in greater detail later that as a JMO you'll encounter and have to manage. The length of stay of patients with hip fractures is also quite long, and looking at the bottom graph, it's on average 6 to 10 days. The mortality associated with hip fractures is very high. In the first 3 months after having a hip fracture fixed, patients have a significantly increased all-cause mortality compared to the general population, and this continues for many years after, if not indefinitely. Studies have also shown that there is a significant increase in survival in surgery that is performed within 48 hours of the injury. Patients with hip fractures do have a life-threatening condition. As they are in a lot of pain and are immobile, they are extremely susceptible to the complications of immobility, including pressure injuries, which can become infected, DVTs, and PEs. And so it's essential that they do go ahead with their operation as soon as possible. We're going to look at a case study. So we have an 84-year-old female who's been unwell with the last 3 days, reporting fever and lethargy. While at home, she felt weak and unsteady while standing up and had a fall onto her right side. She did hit her head but didn't have any loss of consciousness, and the fall was witnessed by her daughter. She presents with a painful and deformed right hip. In terms of her past medical history, she has AF, hypertension, type 2 diabetes, and osteoarthritis. This is a list of her medication. We'll be going through some of the important ones in a little bit. And it's very important to take a social history for everyone presenting with a hip fractures because you need to know their baseline function and mobility. So this patient mobilizes with a single point stick and is independent with her ADLs. So she has a very good functional baseline to start with. In terms of the examination, the patient is alert-oriented with a small head laceration from the head strike. She is febrile, but other OBS are within normal limits. Chest is clear, heart sounds are dual and irregular, which is probably due to AF. She has mild suprapubic tenderness on examination, and a classic shortened and externally rotated painful right hip, which is typical of hip fractures. Very important to check the neurovascular status of the leg and make sure there's no circulatory compromise or neurological compromise. Because she did fall and hit her head, it's important to do a full neuro exam to make sure there are no abnormalities there. So the important questions to ask when you're first presented with this patient in the ED are what was the cause of her fall, as well as to find exactly what injuries she has. This is our patient's pelvic x-ray, and you can see on the right-hand side, there's a fracture through the neck of the femur just below the head. And so this is called a right subcapital neck of femur fracture. It's important to do an ECG on all patients presenting with hip fractures. The patient didn't have a typical history suggesting any type of syncopal episode, but any patients who present with a fall secondary to an unexplained syncope need to be investigated for cardiac arrhythmias. So you need to do a baseline ECG as well as consider discussing with cardiology in case they need telemetry to look for any ongoing arrhythmias that might be contributing to dizziness. This particular ECG just shows AF and it's rate controlled, so it's not rapid AF. Baseline bloods are needed for all patients, and because she has a fractured hip, you know she's going to need an operation, so you should take a full panel of bloods. Her baseline hemoglobin is good, so it doesn't look like there was any anemia that might have caused dizziness contributing to a fall. White cell count and CRP are raised, which creates suspicion that she might have an infection going on. The rest of the EUCs and LFTs were unremarkable. You should always take a coagulation profile for anyone who's about to have an operation, as well as make sure they have a valid group and hold. Urine dipstick is needed for all patients before their hip surgery. In particular, this patient presented with fevers, suprapubic tenderness, so she needs to be investigated for a UTI. And the positive nitrites and leukocytes in the urine combined with the raised inflammatory markers do make it likely that she has a UTI. So you should make sure you send that urine for a formal MCS. Also of note in this blood panel is the INR of 2.8, which is an appropriate INR for her AF, and that's what we'd be hoping she'd be on while she has warfarin. But that is important to consider preoperatively because you can't operate on someone with an INR of 2.8. So that's something we'll have to manage shortly. Other important investigations to order are a chest x-ray. This is both to look for any chest infection that might have contributed to the fall or raised inflammatory markers, but also a chest x-ray is needed pre-op before the anesthetic. A CT brain is also required for this patient. Not only has she had a fall and a head strike, but she's also on warfarin, so you need to make sure she doesn't have any bleed as a result of the fall. It's also important to see if there was any neurological event such as a stroke or bleed that was in fact what contributed to the fall. So that's sort of a summary of the workup you do for this patient when she first comes into ED. Some patients have a very typical history for a mechanical fall. They were alert and oriented and tripped over something and tell you exactly how they fell. But for many other patients, you have to rule out serious causes of the fall. With the main things you would think about are infection, arrhythmias, and neurological events. So now that this patient has a diagnosis of a hip fracture and needs an operation, there are a lot of things to consider preoperatively that have to be managed. So the bloods have already been taken, we've gone through the chest x-ray to ECG, and a urinalysis has been sent. All patients with a hip fracture will need a catheter inserted because it's impossible for them to mobilize to the bathroom until their hip is fixed. In terms of antibiotics preoperatively, these will be required if the patient had any concurrent infection that contributed to their fall. So this patient most likely has a UTI and should be started on the appropriate antibiotics for that. Whether you choose oral antibiotics or IV antibiotics would depend on how unwell they are at presentation. If they have signs of urosepsis, they most likely will need IV antibiotics. Analgesia is a very important consideration for the patient while they are awaiting their operation. There are two aspects of analgesia for patients with hip fractures. All of them should have oral analgesia with regular paracetamol charted as well as PRN endone if needed. You have to be very careful, especially in the elderly, in terms of opioid dosing, as sometimes a small amount of opioids can cause respiratory depression, so they need frequent monitoring and be careful with the amount that you chart. The other important aspect of analgesia for hip fractures is the fascia iliaca blocks, or FIBs. These are when local anesthetic is injected into the fascia iliaca compartment. And when anesthetic is injected into this space, it will work on both the femoral and lateral femoral cutaneous nerves, providing very good analgesia in most of the sensory component of the hip and thigh. So once that's sorted, the next thing to think about would be anticoagulation. This patient is therapeutically anticoagulated, and that will most likely have to be reversed prior to operation. We'll start by talking about warfarin. So warfarin should be withheld pre-op and the INR should be reversed. The aim is to get the INR less than 1.5, which is when it will be safe to have a major operation. Patients are on warfarin for many different things, and it's important to consider what their risk of clotting is if their warfarin is withheld. So patients who have a metallic heart valve, very recent PE or DVT or other thrombophilia that makes them at very high risk of a clot should be discussed with their relevant specialist team before you reverse their warfarin. Patients who have had DVTs or PEs in the past or recurrent clots, but none in very recent times, are considered moderate risk. And patients such as our case, who are on warfarin just for AF or who have a tissue valve or other atrial septal defect, are considered at lower risk. In order to reverse warfarin, first it needs to be withheld, and then because the INR is unlikely to drop on its own accord in the 1 to 2 days before the operation, they might often need IV vitamin K to reverse the INR. If the INR has to be reversed more rapidly or the vitamin K is not sufficient, they might need fresh frozen plasma or prothrombin X to also reverse it. For these cases, they should be discussed with hematology and or cardiology. For example, if they have a metallic heart valve and they're high risk, you might need to bridge with heparin or clexane, which means that while you're reversing the INR, you therapeutically anticoagulate the patient with either heparin or clexane. These are used instead of warfarin because they can be ceased a lot sooner to surgery. So heparin should be ceased 6 hours before and clexane 24 hours before, but they just reduce the risk of the patient having a clot or stroke while waiting for their operation. Other types of anticoagulation might need to be considered depending on the patient. So NOACs, apixaban, rivaroxaban, and dabigatran usually need to be withheld for about 2 days to reverse, but the recommended guidelines suggest anything from 24 to 72 hours depending on the patient's renal function and what dose they're on. So you need to sort of look at those things as well. And dabigatran is the only one that can be reversed if it has to urgently. Antiplatelet agents generally take longer to reverse. So aspirin would need to be withheld for 5 days and clopidogrel for 7 days before their effect is reversed. And with hip fractures, you usually cannot wait so long for this. So normally they will still go ahead and get their surgery even if these agents have not been withheld for the full duration. And studies have shown that there is no increase in mortality or bleeding if surgery is done in less than 48 hours while the patient is on clopidogrel. So in terms of the risk and benefit, it's more important that they get their operation within 48 hours than it is to wait the full time for just a very non-significant change in bleeding risk. So that's anticoagulation, and now we're going to talk about glycemic control and managing diabetic medications in the perioperative period. So the most important medication I wanted to discuss that this patient is on is SGLT2 inhibitors because these medications create a risk of euglycemic ketoacidosis if they're taken when patients are fasting or they have an ongoing infection or dehydration. So this patient will be fasting for operation and she also has a UTI, so she is at risk of euglycemic ketoacidosis, and it's very important that her ketones are regularly checked even if the BSLs are within normal range. Endocrine should be consulted for advice if there's any uncertainty regarding this, or you think the patient is going into euglycemic ketoacidosis. Generally, they should be stopped for at least 3 days around the operation. Other oral antihypoglycemics like metformin can be continued and then just stopped on the day of surgery. For patients who are on insulin, they can continue to have their long-acting insulin the day before, but fast-acting insulin should be withheld on the day of surgery when they're fasting. And they should get an insulin dextrose infusion on the day of surgery, and BSL should be very regularly monitored to ensure control as stringently as possible. So just as a summary, for our patient's medications, her warfarin will need to be reversed. And because she's low risk, she most likely won't need any bridging heparin or clexane in this particular situation. Aspirin should be withheld on the day of surgery, metformin withheld on the day of surgery, and empagliflozin withheld immediately on admission to hospital, and she should wait at least another 2 days to 3 days, depending on when she last had her dose before the operation. It should be discussed with endocrine, who can provide advice as to exactly how long you should wait to withhold that, taking into account that you really want to operate within 48 hours. We're going to touch very briefly on the operative management of hip fractures. Just looking at the top right-hand corner, the blood supply to the femoral head is an important consideration that determines the management. So the retinacular vessels, which supply the femoral head, come from below up through the neck. There are two classifications of hip fractures, to broadly classify them. Intracapsular fractures are fractures through the neck, and these fractures will interrupt the blood supply to the femoral head, and so there is a risk of avascular necrosis to the head. Fractures which are lower down, such as intertrochanteric or subtrochanteric, do not interrupt the same blood supply. In terms of managing these fractures, for intracapsular fractures, because the femoral head has an interrupted blood supply, it's usually decided to replace the femoral head instead, whether that's with a total hip arthroplasty or with a hemiarthroplasty, which is when the femoral head is replaced but the native acetabulum is kept. For extracapsular fractures, these can be fixed instead of replaced, which means that the original femoral head is secured back into place. Some options for this might include dynamic hip screws or gamma nails. So now that the patient has had her operation, we're going to go through some of the post-op management issues in terms of looking after her when she's back on the ward. Post-op bloods are very important, and all patients must have bloods on at least day 1 after their procedure. And usually they'll have it on, say, day 3 and day 5 after, just to check how things are going. Particularly of importance is the hemoglobin. You want to know how much hemoglobin dropped during the procedure. So for our patient, hemoglobin was 103, so that's not too low. Some patients are higher risk and need a higher hemoglobin target. So for example, if your patient had a post-op hemoglobin of 89, some patients might be able to tolerate that, but for others who have a history of ischemic heart disease or renal disease, they're at much higher risk of having a non-STEMI from lack of oxygenation, and so they need a much higher hemoglobin target. So you need to consider the patient's risk factors and whether they need a transfusion or not based on their post-op hemoglobin. The other important blood panel to perform for all patients with hip fractures are the Jerry's bloods. So that includes vitamin D, vitamin B12, folate, and thyroid function. For our patient, her vitamin D was quite low at a level of 10.4, whereas the rest was normal. Vitamin D, B12, and folate are very easily replaceable, and there's something that should be checked in all Jerry's patients and replaced if necessary. So looking at the classification of vitamin D deficiency, which is found on the therapeutic guidelines, our patient falls into the severe vitamin D deficiency and should be started on replacement straight away. The next thing to consider is post-op analgesia, and again, you should make sure that all your patients with fractures are on regular paracetamol as well as PRN opioids. In terms of antibiotics, surgical prophylaxis is something that all patients with hip fractures will be on, and that's usually IV cefazolin unless they have an allergy. Surgical prophylaxis only continues up to 24 hours afterwards. After that, they don't generally require any antibiotics, but because our patient came in with a UTI, she might still be continuing her original UTI antibiotics depending on what you decided to give in the total course of that. DVT prophylaxis is very important for all orthopedic patients because it's a significant surgery involving the lower limb and they have reduced mobility afterwards. So you need to consider what DVT prophylaxis you'll put the patient on. When it's safe to restart her warfarin post-op, when your team tells you that you can restart it, then she might still need DVT prophylaxis level of heparin or clexane just to act as prophylaxis until the warfarin becomes therapeutic again. But again, that's very patient dependent. Aperients are also extremely important. Patients are less mobile and often on opioid medications, and so they're at very high risk of constipation. So you should make sure that everyone has regular aperients charted, whether that's Movicol or cloxazina. You don't want to wait for them to become very constipated first before charting. You should do that as soon as they come back to the ward. In terms of restarting diabetes medications, metformin and other diabetic medications can be restarted when the patient's eating and drinking again postoperatively. For SGLT2 inhibitors, it's recommended to probably wait at least a day before restarting and ensure that the patient is definitely getting their full oral intake before you restart it, just to make sure you don't increase any risk of euglycemic ketoacidosis. If the patient is otherwise unwell and or still has any active infection, you definitely should not restart the SGLT2 inhibitor until they've fully recovered and are eating and drinking again. So for our case study, the first night post-op, our patient became acutely confused, disoriented to time, person, place, attempting to climb out of bed. This is a very common scenario for patients with hip fractures, and what she has is post-op delirium. Post-op delirium, there are a lot of contributing factors, and you need to consider all of them to see if you can figure out what is causing delirium. For many patients, even just being in a new environment and losing the routine, particularly if there is a background of cognitive impairment, is enough to push them into delirium. But as well, they've all most likely had either GA if they haven't had a spinal, and that can definitely contribute to delirium. You need to examine the patient's bloods. There's any signs of infection or electrolyte disturbance can contribute to delirium, and you should look at that Jerry's blood panel and make sure all the B12 folate is being addressed because that can contribute to cognitive impairment as well. You need to examine the patients for any signs of focal infection because infection definitely drives delirium, as well as look if there's any acute issues. So any other acute illness that the patient develops can cause a delirium on top of everything else. One very important aspect is to review their analgesia and medications. This can be a very tricky balance because opioid medications can worsen a patient's delirium, but also pain can worsen a patient's delirium. And when patients are delirious, they can't really tell when they're in pain or ask for pain medication. So it can be very hard to figure out which one is the contributing factor. Other psychogenic medications that might also be contributing are, say, benzodiazepines. If the patient is on these in addition to opioids, the combination can cause them to be delirious. But on the other hand, if patients are regularly on a medication or alcohol and are withdrawing, that can also be a cause of their delirium. So you need to look at the whole full medication list as well as what they regularly take. And other simple things like constipation and urinary retention are very big drivers of delirium. And these are things that should be prevented in the first place if possible, or very readily fixed if you identify them as an issue. In terms of managing delirium, it fluctuates and is reversible. You should always attempt non-pharmacological management first. So simple things like moving the patient to an area where they can be watched more closely in a well-lit area, reorientating and reassuring them, putting familiar objects and clocks and calendars around, distracting them if possible. Many of these patients might need closer supervision or a one-to-one nursing special if needed, just to keep them safe and continue to reassure them. And if they're trying to climb out of bed or are at risk of falling, converting their bed to a low bed close to the ground might also be helpful. The main treatment of delirium is to find what is causing it, so addressing all those contributing factors, and when they are resolved, the delirium should hopefully resolve as well. Pharmacological measures such as using haloperidol or other antipsychotics should only be a very last resort if the patient is a danger to themselves or others and can't be managed in any other way. You should definitely always seek advice from the ortho Jerry's team or your registrar first before prescribing any of these, as they do come with their own risks, such as increasing the risk of stroke, and they in themselves can also worsen a delirium because they are antipsychotics. So those are most of the post-op management considerations. We'll just talk now about allied health because the multidisciplinary team is extremely important for hip fracture patients, and you definitely will be working as a team and should discuss the patient regularly with all the different members of the allied health team. So physio should start seeing the patient from day one post-op. Most of the time, they're able to weight bear on that leg immediately, and they should start their physio as soon as possible. Physio will assess the patient's progress, and they need to make sure the patient is at a level of mobility that's safe for them to manage at home on discharge. This sort of target will vary depending on the patient's premorbid function as well as their home environment, the number of steps they have to access their house and different rooms, what aids they need to mobilize, and sort of who's around to support them at home. So it's very patient variable. Physiotherapists will also assess the patient's need for rehab. So after observing their progress for a few days, if they think the patient needs a longer period of time to get back to safe mobility, then they might be suitable for transfer to rehab instead. Occupational therapists are also very important. They will provide a functional assessment and see what patients need to help them manage their ADLs on discharge. This can include referring the patient for home aids or modifications, things that will help the patient manage at home by themselves, and also to make sure they're safe and discharging and are able to look after themselves. Again, what the patient needs is very variable and dependent on their baseline. Social work is also very important. If patients need an increased level of care on discharge or their carers need further support, then social work should definitely be involved. They can arrange for the patient to be referred for services such as meals, shopping, cleaning, or if they need sort of aged care assessments. Patients are going to be at a much lower baseline than they were pre-injury, and if they might require sort of placement in nursing home, then social work should definitely be involved as early as possible. There are many other allied health members who contribute depending on the patient's specific concern. So this might involve dietitians, speech pathologists, and pharmacy. And often they will offer community follow-up as well. So for example, patients who are very frail often are malnourished and would benefit from dietitian input. And community dietitians are able to follow up with the patients afterwards to see how they're going in terms of their nutritional status afterwards, because that's an ongoing concern that needs to be looked at. So the very final thing is the discharge planning. So our patient makes a good recovery, and after 3 days is mobilizing safely enough to return home with outpatient physio. Occupational therapy have arranged for her to have a shower chair to help at home, and her social worker has helped to refer her for cleaning and meal services as well. Once everything has been arranged for the patient to be discharged, your final role as the JMO would be to make sure the patient has a very clear discharge summary and plan, because this is the communication to the GP about what has been done for the patient and also what follow-up is required. So if the patient needs to see orthopedic team for follow-up in the future, you need to clearly document the arrangements for this, or if you want the GP themselves to do the follow-up, you also need to communicate this. All patients will need a wound review, usually at around 2 weeks post-op, so you need to write clear instructions for this. DVT prophylaxis on discharge is very important. So any patient who's had a hip surgery will need some form of DVT prophylaxis for a period of time when they're discharged. It will depend again on the patient. So because our patient was on warfarin, she will most likely restart her warfarin. Restarting warfarin is usually at their usual maintenance dose. So if she was on 2 milligrams, you would restart on 2 milligrams and give her some sort of DVT prophylaxis until the INR becomes therapeutic. So you need to make sure they have some sort of arrangements or ability to get their blood checked in the community so their INRs can be monitored and the GP can advise them as to what to do. Patients who are very high risk on warfarin might need bridging Clexane on discharge as well until their INR becomes therapeutic again. If patients are going to need Clexane on discharge and they're not used to giving themselves injections, say for example they're not normally on insulin, then you need to make sure that they have Clexane education and are taught how to safely inject their DVT prophylaxis. Analgesia on discharge is very important. You need to make sure you give the patient enough that they will be able to continue to manage at home. And if you're starting a patient on opioids on discharge, you need to give a very, very clear plan as to when that should be ceased, because the last thing you want to do is start someone on an opioid and they continue taking it forever. If patients still need antibiotics, say for our patient's UTI, then that should be continued and provided on discharge. And you should also advise all patients to continue their regular aperients while they're on opioids. Another important consideration would be the osteoporosis screen. If your patient has never been screened for this before, it's probably worthwhile advising the GP to arrange this for the patient, as most likely they will have osteoporosis and this could be treated in the future to prevent further fractures. So that's all for the presentation today. Please let me know if you have any questions. Thank you.